Next speaker is Dr. Nikhil Agarwal. HIPEC, how much difference does it make?
Good morning, everyone. So I'll be talking about role of cytoreductive surgery and HIPEC in colorectal cancer. So let me ask you a question. How many of us are willing to do a liver resection for colorectal liver metastasis? Can I get a show of hands? Thank you. And how many of us will do a CRS HIPEC for a peritoneal metastasis? Okay, so that's what I expected. So the numbers are less. Now, why so? Right, so this is a question which should come in our mind. So as a GI surgeons, we are little reluctant to do these procedures because we are not probably very well versed with this, while we can see the survival outcomes are almost equivalent. So this should be in the armamentarium of all the GI surgeons. When we see a colorectal cancer with resectable peritoneal metastasis, we should be think of doing CRS HIPEC. Now, why? So most of the colorectal cancer patient, whether they will have this synchronous or metachronous presentation. So 5% of them will have isolated peritoneal metastasis as synchronous presentation, and 20% of them will have this in developing later, and almost 1/3 of it will have isolated peritoneal metastasis. So broadly around 10% of colorectal cancer patients in synchronous or metachronous setting will have isolated peritoneal metastasis, and they are potential candidates for CRS HIPEC. Now the problem with peritoneal metastasis is that systemic chemotherapy is not effective. In fact, compared to pulmonary and liver metastasis, peritoneal metastasis has worst outcome with systemic chemotherapy, right? And the reasons are obviously poor vascularization, there is a plasma peritoneal barrier, and AJCC has especially classified this as M1C. So even with modern cystic cancer targeted agent and everything, the survival which we can achieve with systemic treatment is around 18 to 20 months. Now intuitively it appears that if our systemic chemotherapy cannot reach the peritoneum, probably local therapies will help. So that's how it came. So initially people tried local therapies and the penetration was around 1 to 3 millimeter. Then heat was shown to increase the penetration to around 5 to 7 millimeter. Then Sugar-Baker introduced in 1995 complete peritonectomy procedure. It was a very morbid procedure. There were 6 procedures involved, like enterectomy, complete peritonectomy, sigmoidectomy, and with this he showed a good outcome. Later on it was realized that with complete cytoreduction for macroscopic disease and with HIPEC for microscopic disease, which it will be able to potentially eliminate all the possible disease in the peritoneum, and it was shown to improve outcomes as well. Another advantage of HIPEC is that the chemotherapy is absorbed through the portal system and it is detoxified directly in the liver, so the systemic effect is less. Now, Netherlands trial was the first trial of CRS HIPEC in colorectal cancer. The accrual was in 1998 to 2001, and this trial showed with mitomycin C 90 minutes and with adjuvant chemotherapy, the median OS improved from 12 months to 23 months approximately, and the later follow-up study with the 8-year follow-up was published in 2008, and it showed that PFS and disease-specific survival was still on the positive side, and the cohort specifically which underwent complete cytoreduction, the 5-year OS in this trial was 45%. There was some criticism of this trial. In the chemotherapy, only single agent chemotherapy was used, and mortality in the CRS HIPEC worm was 8%. So there were 2 more trials following this. They are not RCTs, they are basically cohort studies, 2 and furthermore, but I will just highlight the 2. One is from the French trial from which the oxaliplatin came in, and here the modern systemic chemotherapy were used in patient, and a mean of around 2.3 lines in each patient. And in this also, the 5-year overall survival improved from 13% to 51% with addition of CRS HIPEC, and the median survival was 23 months versus 63 months. And the similar type of outcome was shown in America in Pittsburgh study as well. So this is from a meta-analysis which looked at all the trials, including RCTs and cohort studies, and it consistently showed improved survival with CRS HIPEC. So this is the hazard ratio from the studies, comparative hazard ratio, and all the studies which has looked into CRS HIPEC versus systemic chemotherapy has shown significant improvement in survival following this procedure. So how does it play out? So I'll show you one example of a patient which has peritoneal disease to start with. So this patient has peritoneal disease which is mostly localized to the right side of the abdomen. PCI was 10 and it was a mucin secreting adenocarcinoma. We gave neoadjuvant chemotherapy to this patient. There was good response. This is the post neoadjuvant chemo CT scan, and this is the disease during surgery. So you can see the peritoneum is studded with nodules, and then you achieve complete cytoreduction, and then you do HIPEC. Now, so CRS and HIPEC was an established procedure, but obviously the role of HIPEC is being called into question following the PRODI-7 trial, which was published last year. So this was a French trial, and in this patients were, after complete cytoreduction, divided into two arms. So one arm received HIPEC and one arm didn't receive HIPEC. Here the agent used for HIPEC was oxaliplatin. And in this trial, the overall survival, which was the primary endpoint, was equivalent in both the groups, and it was excellent but equivalent. So both of the arms showed a median survival of OS of around 43%. And the HIPEC arm had a delayed adverse events, grade 3 or more, 60 days and beyond. And in a subset analysis, the patients who had PCI between 11 to 15, they showed a better response with HIPEC. Now, there are many criticism of PRODI-7. In fact, if you look at the literature which came in following this and the letter to the editor and the reply to that there was a flurry of responses to this thing, because intuitively it appears that HIPEC for microscopic disease should be done, and this trial actually challenged that dogma. So still people have not stomached the finding, and but these are the kind of criticism which was there. Like one of them was that in the control group, 12% of the patients crossed over to receive subsequent CRS HIPEC. These patients were heavily treated with oxaliplatin, which is known to induce oxaliplatin resistance, which was the drug used in this trial. And there were some questions on the fluid, some questions on the concomitant IFU, some questions on the dosing, and some questions on the adjuvant therapy. So after that, POSGI, which is a body which looks into peritoneal surface malignancy, they did a survey, and the practice has changed from oxaliplatin to mitomycin mostly all across the world. However, looking at the trial data from previous, they are almost known to be equivalent. So after the HIPEC, like there are two ways to deliver HIPEC. We can do an open or a closed technique. Most of the centers used a hybrid, so where you just covered the open one with an sheet and then you deliver the drug. Now, as with all other tumors, tumor biology and patient selection are the most important factors. So the red flags are aggressive tumors, young patients, and signature histology has specifically shown to have poor outcome. Obviously, a patient with severe comorbid illness and advanced age are exclusions. And if we specifically look at signaturing histology, the outcomes, the long-term cure rates are poorer, but still that doesn't exclude these patients from receiving CRS HIPEC, because the survival will still be better compared to chemotherapy. But yes, we should know that these patients are going to land up in poor outcome. Now, one of the very, very important quantifiable factor in these patients is peritoneal carcinomatosis index, and which is a very, very crucial factor when we take up these patients for surgery. Now, laparotomy is the best way to identify or quantify the peritoneal carcinomatosis index, but obviously we have to do it through non-invasive methods before we take that call. So radiological PCI is one way to do it. Now there is a debate between CT, MRI versus PET-CT, and PET-CT is slightly better than CT, and MRI is still evolving. Some people say it's better, but we mostly use a combination of cross-sectional imaging, mostly PET-CT, along with staging laparoscopy when we take a call when to do this. Now, most of the centers will use a cutoff of 16, some centers will use a cutoff of 20, and in the PRODI-7 trial, we just discussed the cutoff was 25. Now, this is how we calculate PCI. So the abdomen, as usual, is divided into 9 quadrants, and 4 more quadrants for upper jejunal, lower jejunal, upper ileum, and lower ileum. 0, 1, 2, 3, no tumor, tumor up to 0.5 centimeter, up to 5 centimeter and more than 5 centimeter, or even a conglomerate mass more than 5 centimeter. Based on that, you calculate PCI, and a PCI of 16 is generally taken as a cutoff where we take these patients up for surgery. Now, to even make the patient selection better, we have to look at certain criteria. Of course, performance status is one of the things, then extra abdominal disease. Limited extra abdominal disease is not contraindication. Like one of the consensus statements looked into this, and a nomogram was developed, and up to 3 or 4 liver metastasis is okay. There shouldn't be any biliary obstruction, hepatoduodenal ligament shouldn't have much disease, ureteral obstruction shouldn't be there, there shouldn't be gross small bowel and mesenteric involvement. That's a big no-no, and one of the problem with this is that CT is not CT performs worse in finding small bowel and mesenteric involvement. So this is generally detected on staging laparoscopy and sometimes at laparotomy, and gastrohepatic ligament should be relatively free. Now, once you have achieved this, or once you are going to do surgery, the CC score, completeness of cytoreduction score, is something which is very important. So we should strive to achieve a CC 0. It means that macroscopically we have removed all the disease. So it is quantified as CC 0, no residual disease, CC 1, residual disease less than 2.5 mm, and then 2.5 to 2.5 centimeter, and more than 2.5. AJCC also gives R criteria, R0, R1 we all know. R2A is disease less than 0.5 centimeter, R2B is disease 0.5 to 2 centimeter, and R2C is more than 2 centimeter. Now, CC0 and CC1 has been shown to be the best predictors of long-term cure rates, and initially some data suggested that both are equivalent, but now we know that CC0 is better than CC1. And so this is how we quantify. I mean, this is like one example of a patient who has disease on the right upper quadrant along the liver, and then you do a complete peritonectomy on the right side and even a glycinectomy, and you achieve a CC0. Similarly, this is the left upper quadrant. This is a high volume disease. This is not for colorectal cancer. This is, but I just have taken this image to show you the example. And this image you can see is the pelvis. So these are the ureters here, and completely exposed, and like you achieve a CC0 here. So obviously it's a major procedure fraught with morbidity and mortality. Morbidity is around 30%, which is close to a Whipple procedure, and mortality is around, like obviously the older studies showed higher mortality. The recent studies showed lesser mortality, and it's dependent on the disease volume. And to improve the outcome, obviously high volume centers, more number of cases, and system need to do a lot of these cases to develop that level, and surgeons also need to have around 100 to 200 cases to develop that exact proficiency levels. So to summarize the whole thing, a significant proportion of CRC patients will have isolated peritoneal metastasis. Not very good survival with modern systemic chemotherapeutic agents, but addition of CRS, maybe with or without HIPEC, we probably need more data to clarify this, and we can extend the survival significantly and meaningful way, and patient selection is the key to success. Peritoneal carcinomatosis index is something which is very important. We should strive to achieve CC0, and with increasing volumes we can get better outcomes. Thank you very much.
Nice presentation. Any question from the audience?
Excellent talk, sir. Sir, my question is, if you, we all can understand that systemic neoadjuvant therapy is mandatory in this situation because this is a systemic disease to begin with. But many a times when the CT has not picked up a peritoneal disease, and in diagnostic, and the tumor is large, it's bleeding, and now in the laparotomy or laparoscopy you have found that there is a PCI which is 6, 7 or 10, less than 15, and it's an upfront case. So what should be the management protocol then?
Yes.
And the tumor is bleeding, so you have to resect the primary.
Excellent. So you have actually asked 3, 4, 5 questions there. So one, neoadjuvant chemotherapy is not mandatory. We do give neoadjuvant therapy for most of these patients, but if we look at the data, none of the data so far, maybe one retrospective series showed some advantage, but mostly you can do them upfront. Neoadjuvant therapy is not mandatory, and there is one Cairo 6 trial which is ongoing, which will throw more light on this, but it's not mandatory. Second, when we talk about patients who are found to have peritoneal metastasis at laparotomy or laparoscopy, so we can divide these patients in two sets of patients. One, a patient which was taken up for elective surgery, so who's asymptomatic, not bleeding, not in obstruction. So two ways we can tackle the situation. We can go ahead with upfront CRS HIPEC, no harm with that. But the problem is that that kind of conversation that hasn't taken place with the surgeon. See, the kind of conversation we have with the patient when we are taking up that patient for a elective left or right colon procedure, vis-a-vis when we are taking up that patient for CRS HIPEC, right? So the morbidity, the expected mortality, the cost, everything is hugely different. So mostly we do not do this, right? So in an elective patient, when we get peritoneal disease, we generally take biopsies, come out, give neoadjuvant, go back again with all the preparation and then do it. In emergent setting, again the same question will arise because you have to remove the primary. So if you can do CRS HIPEC with low volume disease, you specifically mentioned a PCI of say 5, 6, we can go ahead with CRS HIPEC if the patient's situation permit. Otherwise, we can use the same strategy which we used in elective, that do the colon, give neoadjuvant and go another day.
Thank you, sir.
Thank you.
Hi, Rohin from Alok. Excellent presentation. I think the message is very clear that CRS and HIPEC is possible and these patients are not to be left as a palliative setting. My question was very similar to the previous one, saying, if you are in a situation where you put in a laparoscope and find limited peritoneal disease, many people will just do a limited peritonectomy and come out. But that is not the way to go. I think you've answered that. My second question is, sometimes you have a patient who we have resected the primary and has come back to you at 1 year follow-up, and you have a few suspicious peritoneal nodules here and there. What is your protocol in that? How to prove that these are peritoneal metastasis? Diagnostic laparoscopy is difficult because there will be additions. So how do you go around saying that this is peritoneal nodules and then offer them a CRS HIPEC?
So I guess the way forward here will be the size. So if your intervention radiologist can sample some of them, fine. Obviously, we'll look at antecedent things like say what happened to the CEA, what happened to the symptoms, how was the primary, do you expect a recurrence or not. So if you strongly suspect there is peritoneal recurrence, obviously you have to prove it. So if you can prove it non-invasively, fine, otherwise maybe a staging laparoscopy or even laparotomy you have to do. Now, management will depend on, again, disease-free interval, what is the status of the patient, and yes, maybe if the patient has received adjuvant, we can give neoadjuvant again and then do the surgery, or you can upfront also we can do. I mean, that data is not clear here.
Dr. Nikhil, wonderful presentation. Just 2 comments. One is on what Rohin said about very limited disease, and I wouldn't go to 5, 6. Maybe you're doing a right colon, the adjacent peritoneum just shows a 0.5 centimeter deposit there. No harm in taking it out. Largely cytoreduction, limited cytoreduction without HIPEC also improves survival in these patients. That's one comment. And second thing is, generally for all the people who are sitting in the audience, quite often what will happen is we'll put a scope inside, but we wouldn't have documented the PCI. Seems a very, very complicated score. One thing, the diagram is very freely available on the internet. Right after the surgery, go to the computer, take a printout and start putting it. You'll realize that quite often when we have written deposits all over the peritoneal cavity, it is just 0.3, 0.5 millimeter deposits, and the total PCI will not come very high. So that's a very important thing that people have to understand, that disease all over the abdomen, the size matters more in the calculation of the PCI than the number of sites the disease is. So that's very important to document, and because it will change the entire way that the medical oncologist, or you for that matter, would look at that patient.
I'll add just a couple of points there. Like one, you have to document them. So one, you document them, and two, also take photos and videos. That helps, especially if some center is not doing that thing routinely. Two, you have to look for peritoneal metastasis. So generally, if you are doing a staging laparoscopy, you just put in a scope and see. But when you are doing a staging lap for these things, put in 2 more ports, look at the HDL carefully, look at the pelvis very carefully, reflect the omentum, look at the small bowel, look at the lesser sac. So it has to be a more diligent staging laparoscopy than we just put in a scope and see it. So that's very important.
Absolutely, and I think just to go on to that, I think the important part in this whole operation is the cytoreduction. The HIPEC is just the icing on the cake. You mentioned that in the Prodigy 7 trial, but I think that's for everybody to understand that a good cytoreduction is what will lead to improved survival. HIPEC will just add a little bit to it.
Yes, you are absolutely right there, but a more nuanced approach will be cytoreduction is probably okay for low PCI, but even we look at the subset analysis of Prodigy 7, in 11 to 15 is the group where probably the HIPEC will add value.
Sir, total or a selective peritonectomy?
Selective.
Would you change that if your patient, you've not done a staging lab upfront and then you are doing surgery next time? Would you change selective versus extensive, especially if your patient has received neoadjuvant?
I will still go for selective.
Dr. Shivendra, you want to comment on that?
Yeah, it will be selective only because total peritonectomy has not been shown to be beneficial. But post-chemotherapy, it is many times difficult to assess. So it is better to have a laparoscopy and assessment prior to neoadjuvant chemo.
Thank you.
If there are no other questions, we'll end this session here.